Good morning, everyone. I, Dr. Yogesh Harwani, on behalf of Association of Physicians of Ahmedabad and Noble Gastro Hospital, welcome you all to 17th Clinical Summit of Advanced Gastro Summit 2020. So from today onwards, we will be having video lectures, and it's my pleasure and it's an honorable moment for all of us to have two legends here who have very much good experience in cholangioscopy and pancreatoscopy. Sir, greetings from Ahmedabad, India. Dr. Moon, namaskar. Sir, it's an honor to have you here. And today we have moderator Dr. Piyush Somani, but he has not joined or he may join late because he had some medical emergency. I would like pleasure to introduce our chairpersons, Dr. Somin Shah, who is a good friend. He is from Surat, western part of India, and he is very enthusiastic and young gastroenterologist who runs and gastroenterology and vascular hospital. And we have Jeffy George, who is also a very long time good friend. He is from Cochin and a very young and enthusiastic gastroenterologist. So Dr. Jeffy, please introduce Dr. Moon, and Dr. Somin, please introduce Dr. Rajput, and then we can begin our talk.
Thank you, Yogesh, for the invitation. It's my great privilege and honor to introduce to you Professor Jong Moon from Soonchunghyang Hospital, University School of Medicine, Bucheon, South Korea. So Professor Moon is an expert and authority in cholangioscopy. His areas of interest include single operator cholangioscopies, the management of distal biliary strictures and malignant biliary obstructions. And apart from academics, he's an excellent human being, and even I had the privilege to work with him when he was our mentor during our IDEN fellowship way back in 2015. So welcome aboard, sir, and we look forward to your talk. Thank you, sir.
Hi. So, Dr. Sanjay Rajput, I think name needs no introduction in India. He is a master endoscopist.
Somin, you are not audible.
Now, am I audible?
Yes.
Okay. Dr. Sanjay Rajput is inspiration to many of the young gastroenterologists of India, and he is excellent endoscopist as well as excellent gastroenterologist. Whenever we have some difficulty during the procedure or some clinical cases, we can freely communicate him. He himself is a institute as per my opinion. So he is doing each and every procedure, including third space, spyglass, and endoscopic ultrasound. So thank you, sir, for guiding us, and we will hope you are guiding us throughout our career. And without wasting the time, now we ask Dr. Moon to start the lecture.
Santosh, please run the video. Technical team.
Arvind, please make it live.
Thank you very much, Mr. Chairperson. It's my great honor to joining here, especially thanks to Yogesh to having me to this kind of fantastic meeting. It was the first meet with Yogesh in Seoul in 5 years ago. This is a little bit old photo, but very meaningful for me with Yogesh. Cholangioscopy provides direct visualization of the biliary tree for diagnostic and therapeutic procedures. But it is difficult procedure comparing with routine gastro and colonoscopy. New types of cholangioscopy is a single operator system like a spyglass or direct POC. The spyglass system from Boston Scientific provides very useful direct visualization of the biliary tree. Now we are having spyglass DS. Spyglass DS system has many advantages comparing with spyglass legacy, So it is becoming the standard of POC at present. You can compare the imaging quality of Spyglass DS with Spyglass Legacy. Spyglass DS is much better than Spyglass Legacy. Now, third generation Spyglass DS2 was developed. It has better image quality than Spyglass DS with automatically adjusted lighting to reducing central hotspot and light flare. New SpyBite Max biopsy forceps for bigger tissue sampling is coming for more accurate diagnosis of malignancies. These are important diagnostic indications of POC, like evaluation of indeterminate bile duct lesions or intraductal tumorous lesions and surveillance. Let me show a case. Cholangiogram of this case shows just a small filling defects on bile duct. But on Spyglass DS, findings are completely different with only ERCP. As you can see, many papillary cluster-like lesions with tortuous vessels on surface. With each touch bleeding was revealed. This case showed the suspected filling defect like biliary stricture on proximal CBD near cystic duct take-up. At first, IDUS revealed a luminal protruding flat elevated mass lesion from bile duct. Spyglass DS was performed to find the lesion. Flat but elevated mass lesion having flux pond-like projections showed in the bile duct. Process biopsy using SpyBite was done on direct visualization. Histopathology result demonstrated adenocarcinoma from intraductal papillary neoplasm in the bile duct. Uday reported high diagnostic accuracy of process biopsy on Spyglass DS for indeterminate biliary strictures. Some interventions can be possible on Spyglass. Endoscopy lithotripsy can be the most common interventional procedure. This cholangiogram shows impacted distal CBD stone. It failed to removal using conventional method. Spyscope was inserted and laser lithotripsy is performing on direct visualization for this impacted stone. Endoscopy ablation using phorodynamic therapy can be possible on Spyglass DS. Cholangioscopy shows an obstructing mass lesion in the proximal bile duct. Photodynamic therapy was performed on POC. Therapeutic interventions can be expanded beyond lithotripsy. For this case, Spyglass POC was done for the removal of proximally migrated metal stent in intrahepatic duct. After insertion of a spy scope, metal stent was captured with spy bite and then it removed it slowly. Especially with new accessories like this basket from MTW endoscopy and new spyglass retrieval basket or snare, therapeutic interventions will be increased. Let me show a case. After removal of stone with mechanical lithotripsy, spyglass POC was done for any remnant stones. You could see fragmented stone. And stone was captured with a basket on direct visualization and removed it slowly from the bile duct. The endoscopic view shows removal of stone with basket on spyglass. However, still spyglass DS system has several disadvantages to be a routine clinical practice. Direct POC is direct insertion of ultra-slim endoscope into the biliary tree. The major advantages of direct POC is the high quality endoscopic imaging and up to 2.2 millimeter of large working channel for effective tissue sampling and therapeutic intervention. However, there are several conditions for the successful of direct POC. New multibanding ultra-slim endoscope as a dedicated slim endoscope for direct POC is developing. This is a prototype having 2 banding sections and 2 working channels. Final goal of the new scope can be stability of scope position in bile duct without accessories and the freehand insertion into the bile duct. This video shows freehand insertion of multibanding ultra-slim endoscope for direct POC. Now scope tip is the orifice of ampulla, and then endoscopy is jumping up to the proximal bile duct. Recently, our group reported the result of direct POC using multibanding ultra-slim endoscope to be a real meaning of cholangioscopy like conventional colonoscopy. The technical success rate of direct POC using multibanding slim endoscope was almost 90% without any assistance of accessories and scopes. It compared with 30% success rate of direct POC using conventional slim endoscope. Increasing diagnostic performance of POC can be possible by high-quality endoscopic imaging, each performance of enhanced endoscopy, and effective tissue sampling using bigger forceps for biopsy comparing with spy bite. Narrowband imaging shows detailed images of the surface structure and of the mucosal microvessels. This video shows a luminal obstructing mass lesion on proximal CBD. It looks like a colon cancer. MBI clearly shows the margins and the surface structure of the lesion and mucosal microvessels. Digital enhanced endoscopy like eye scan and FICE may be easier than MBI to apply on POC. You can see a luminal obstructing mass lesion on proximal bile duct, and this is the white light image, and this is the eye scan image. You can also see the normal inner surface of bile duct, and eye scan provides detailed views of the surface structure, mucosal microvessels, and the margin of the lesion. For this patient having CVD stones, direct POC using multibanding ultra-slim scope was performed after stone removal. Multibanding ultra-slim scope is inserted inside the bile duct without any accessories. During POC, a luminal protruding papillary mass lesion was seen incidentally. MBI and forceps biopsy was done on POC. Histopathology result revealed adenocarcinoma. Our group reported high diagnostic accuracy of forceps biopsy on direct POC. Therapeutic interventions of direct POC can be more expanded with a large working channel. Endoscopic extraction on POC can be performed using by conventional 5 or 6 French basket or snare. This patient has impacted cystic duct stone. Stone on cystic duct is very difficult to remove on conventional ERCP. So we tried the stone removal on direct visualization. The 5 French basket is introduced over the stone. After careful capturing a stone, stone is removed from the small cystic duct to the CBD. Endoscopic drainage can be performed by using a 5 French or 6 French stent, especially for patient needs a selective guide wire access. Endoscopic metal stenting also can be possible on direct visualization. Now, small version of 6 French delivery system with metal stent is inserting over guide wire. And then you can see the slowly deployment of metal stent on direct POC. Finally, you can see the nicely deployed of stent inside the bile duct. Endoscopic resection for biliary tumor may be feasible by direct POC in the future. This patient underwent direct POC after stone removal. A small polypoid lesion was revealed on proximal CBD. MBI applied immediately and clearly showed the margin and the surface structure. Polypectomy on direct visualization was performed. There was a case of endoscopic mucosal resection for bile duct cancer on the direct POC. Endoscopic ablation therapy is another promising procedure for the treatment of biliary tumor on the POC. Ergon plasma coagulation, APC, is an effective ablation method. For this patient, APC was performed for endoscopy ablation for this flat elevated biliary tumor. Also, we are developing 6-French RFA catheter for oral cholangioscopy control of RFA. Direct POC was performed with multibanding ultraslim scope. You can see luminal obstructing mass lesion on POC. And now, small version of RFA catheter is inserting a mass through the walking channel. RFA can be done on direct visualization of cholangiocarcinoma. In conclusion, oral cholangioscopy is a useful endoscopy for managing biliary lesions. With the introduction of single operator cholangioscopy, diagnostic and therapeutic roles of POC is expanding for biliary lesions. Thank you for your very kind attention.
Thank you, sir, for your lecture. So, shall we move to the next lecture?
And screen આવતી નથી યોગેશ?
No, sir. We can see your screen, sir.
You can see.
Yes, sir. We can see. I think Jeffy, you can see this sir's screen.
Yes.
We can see.
Good afternoon, Yogesh and Dr. Moon. It was a wonderful lecture, and the future is coming. I am very much pleased to see everything which I wanted to see in my dreams is coming true. So, oral cholangioscope can change the management of biliary and pancreatic disease, and I have dream of doing everything what you have shown, and we have many more ideas to come in future. So pancreaticoscopy, it was started way back in 1976, but because of the double two people using it, and because it was very fragile, it didn't come in very big way, and it is before 10 years only that it has come up in a good way when Boston Scientific had allowed the single operator cholangioscope. Why it is important? Because it allows direct visualization, tissue acquisition, and direct therapies such as stone lithotripsy and many more future things which we can do with the cholangioscope. Why do we need pancreaticoscopy at all? Because as we know that CBD we can evaluate with many more things, and evaluating PD is challenging due to its anatomy. They have a limitation of cross-sectional visualization even after best CT, MI and EUS guidance. Sometimes we miss few things in IPMN like disease where this can be very useful. It is a relative inaccessible pancreatic duct to endoscopic devices, and pancreatic duct has unique obstructive disease entity, and it has also limitation of the diagnostic and fluoroscopy guided therapy for the people. ERCP guided brush and cytology also has very low diagnostic value in different studies. Even with the addition of endobiliary biopsy forceps and endoscopic needle aspiration, the diagnostic yield and negative predictive value still remains low. Stone extraction by the basket or balloon, also we know that it is very difficult in pancreatic duct rather than CBD because of the narrow proximal PD, different branching and pattern, and there are multiple stricture, multiple stone. They are very hard stone. And we also know that the non-endoscopic intervention for pancreatic duct is not as successful as with common bile duct, and they have significant morbidity and mortality. As sir has shown that slim gastroscope is already there, and stores are making one small scope which can pass through the middle of the scope, middle of the ERCP scope, with a smaller channel, larger channel for the therapeutic intervention which sir has shown. Indications of pancreaticoscopy are diagnostic and therapeutic. Pancreaticoscopy in IPMN, in indeterminate stricture of the main pancreatic duct, and pancreaticoscopy assisted tissue sampling. Therapeutic intervention, we can do pancreaticoscopy guided laser lithotripsy or EHL, pancreaticoscopy guided stent removal, and future therapy as sir has shown RFA, photodynamic therapy are coming in future. As we know, this IPMN has a malignant potential of 65 to 70%. So missing in IPMN, and during surgery, if you remove some part, and some parts we are missing that IPMN, it has around 20 to 30% of the cases. They have IPMN in different locations after surgery, and they have recurrence rate. So efficacy of POP in benign versus malignant mucin producing tumor, they have shown that with surgical pathology, and they characterize them according to the shape of the intraductal elevation and the color features of the lesion. The technical success was around 73% according to Yamaguchi and Hara. They have classified the IPMN according to the villus structure. And as you can see, from granular type to vegetative type. As it goes from granular to vegetative type, chances of malignant potential increases. So from C to E, they are almost always malignant. So if you see a picture like this in pancreaticoscopy, you can definitely see by direct visualization only that you are having a malignant IPMN. Because on EUS, we have seen that sometimes in EUS biopsy also, it is not conclusive that whether this nodule is malignant or benign. They have described 5 features like granular mucosa, fish egg-like protrusion type 2 without vascular margin, fish egg-like protrusion with vascular margin, villus protrusions, and vegetative protrusion. So type 3 to 5 are malignant, and type 1 to 2 is benign. So we can follow up type 1 to 2 gradually, and then we can do this. This is a video of pancreatic IPMN. This is actually an underwater pancreaticoscopy. So as we know that underwater colonoscopy gives better result in visualizing polyp, and gives better anatomical marking. You can see the definite projections. You can see the villi. So it enhances the picture during the underwater pancreaticoscopy. So it is a good modality to use while you are doing pancreaticoscopy. You can see we can do NBI during pancreaticoscopy and differentiate whether this lesion is benign or malignant. You can directly do the NBI with the help of a direct cholangioscope, as sir has shown. It gives very clear-cut images. You can do targeted biopsy with the biopsy forceps from these villi, and you can definitely say that this is malignant lesion. Other scopes are Fuji scopes. They have also come with the direct cholangioscope they are developing, and it is also a prototype. So this can change the management in IPMN. If you do regular endoscopy for these IPMN patients, and you can follow them up, you can pick up the early malignancies, you can do early resection and save a lot of major surgery. Actually, they can guide us with the resection margin also, which I am showing you in the next few slides. Intraoperative POP in IPMN is the main thing which surgeons want to do, because during surgery, if they miss the lesion which is distant to the main lesion, there are chances of recurrence which are missed by ERCP and EUS. So pre-operative thorough direct examination of the PD may be limited due to the acute angle noted at the junction of the duct of Wilson and the Centurion. So intraoperative POPs help in overcoming this problem, and it can change management and the level of resection margin in up to 30 to 60% of the cases. you can change the management. Even the surgery can be avoided if you are examining the during surgery. So Kaneko and Teilberg has already shown that if they can identify the lesion intraoperatively in 100% of the time, where 60% and 62% were during EUS. And out of the 13 patients who underwent POP, the initial surgical plan was altered in 8, means 62%, with an overall correlation of the 88% between pancreaticoscopy and final surgical pathology. So if you do pancreaticoscopy intraoperatively, you can definitely save the patient's pancreas. So this is a case where this MRCP is showing dilated duct in the tail. So in this, EUS was done. EUS was showing there is a nodule in the tail, and with the side branches also dilated. And the nodule you can see. The contrast enhanced EUS also could not pick up whether this is malignancy or not. So pancreatic ERCP was planned and pancreaticoscopy was done. On pancreaticoscopy, you can definitely see that the proximal pancreatic duct is absolutely normal. And while passing through, you can see the normal mucosa of the pancreas, and only tail is involved. In the tail, you can see the papillary projections. There are definite papillary projection in the tail, and the cyst, the mucosa cystic lesion biopsy was done, which showed that it has high-grade dysplasia. So only tail resection was done, and by this, with early malignancy. So surgical resection can be monitored, and it can change the management of the IPMN management. Pancreaticoscopy in indeterminate stricture of MPD, it can differentiate between benign and malignant pancreatic duct stricture, which is often challenging in chronic pancreatitis. As we all know that chronic pancreatitis, EUS also is very challenging. So in those cases, if we can do this pancreaticoscopy, it can definitely differentiate between benign and malignant stricture. It has excellent visual diagnostic accuracy to distinguish neoplasm. The finding on pancreaticoscopy that suggests that this is IPMN or adenocarcinoma, tumor vessels, mucin, ulceration, friability, infiltrative stricture, and protruding lesion, including papillary, polypoid, villiform, or vegetative lesions. While benign strictures they are likely to have band-like scarring, coarse atrophic mucosa, and blood vessels. So POP directed tissue acquisition is useful in diagnosing also benign from malignant lesion. The various studies has already demonstrated that if you do POP and do the targeted tissue diagnosis, benign stricture and malignant stricture can be definitely picked up or very well. Intraductal EUS can be done with the peroral pancreaticoscopy, and it has clearly shown that if it is more than 3 millimeter big, lesion, projections are more than 3 millimeter big, there are chances of malignancy, and it has better efficacy to pick up the early lesion like carcinoma in situ due to higher resolution and probe location as compared to EUS. Direct visualization of indeterminate pancreaticobiliary stricture with probe-based confocal laser microscopy. Dr. Janak and Raj has already shown that it has better efficacy than the routine IDUS and routine pancreaticoscopy, and there is overall accuracy of 81% for confocal laser endomicroscopy compared with 75% for index pathology. Accuracy for combination of ERCP and PCLE was significantly higher compared with ERCP and tissue acquisition alone. This is how the benign stricture looks on pancreaticoscopy, and the villi and the malignant lesion looks on pancreaticoscopy. So these are various studies which have shown that person having a papillary projection, tumor vessels, protrusions, friability, duct cutoff, they have very high chances of malignant lesion in comparison of smooth narrowing, gray mucosa, protein plaque, stones, coarse erythema without having any tumor vessels. They are having more chances of benign lesion. So villous vegetative lesions with red mark correlate with atypical adenoma or carcinoma, and IDEUS has a better sensitivity than POP for detecting protrusion more than 3 millimeters. So if you do IDEUS with POP, it has more sensitivity and specificity than POP alone. So narrowband imaging also can be done with the peroral pancreaticoscope, and it has better sensitivity than POP alone to pick up the malignancy, and technical success for with biopsy or POP assisted or POP directed biopsy, or having the IITV guided biopsy are having better chances of doing only direct biopsy. Main indication of POP is endoscopic pancreatic ductal stone therapy. As we know that pancreatic duct stones are very difficult to remove, and they have a significant target for therapeutic intervention. Stone predominant disease are more in idiopathic or genetic etiology, while alcoholic pancreatitis have chronic multiple stricture with stones. Traditional ERCP using extraction balloon and baskets have a very limited and success, around 50%, even in expert hands. As Yogesh know that we are facing difficulty in doing routine ERCP, we are losing more and more balloons while removing all these pancreatic stones, and there are chances of basket impaction or trapping of the basket during the pancreatic ERCP. So ESW also we know that it is having a very limited availability, cost needs multiple sessions, and even after doing ESWL, we need ERCP. So combined POP has a combined advantage of endoscopy as well as ESWL, and we can do the direct visualization of the stone, and we can see the effect of the stone removal and the stone fragmentation by our eyes. So we can do it by two methods, EHL or laser. There are different studies with around success of 37 to 100% success rate. These are the different cases which I wanted to show on. These are all difficult cases which are not managed with routine pancreatic laser lithotripsy, as sir has shown that you go inside, do the removal of the stone with the routine. But this is a head stone where EUS was used as a rescue method. Patient has a direct large cyst with a dilated duct and the stone. You can see on EUS you can see a very large stone which was impacted in the head, and there is dilated duct. So on ERCP ampulla was normal, but after pancreaticogram it is showing a large impacted stone in the head. So wire was we tried to pass the wire deep into the pancreatic duct, which was unsuccessful. So then again EUS comes as a rescue therapy. After puncturing the pancreatic duct from the stomach, you can see the dye is not going into the lower pancreatic duct. So the guide wire was passed through and it came out through the minor ampulla. Once the guide wire came out of the minor ampulla, by the side of the wire, the sphincterotomy was passed. Pancreatic sphincterotomy was done. You can see the fragments are coming. And then pancreaticoscope was passed over the guide wire. You can see the wire coming out from the stomach. And with the help of EHL, the big stone which was impacted, was removed, and then stenting was done, and the stone was removed with the help of balloon. Again, when there is a stricture at the lower end of the pancreatic duct, it is always difficult to pass the pancreaticoscope. So in that case, we can use a SEMS for the lower end pancreatic duct dilatation with single stricture. And then through the stent, if you pass this pancreaticoscope, you can see a large stone impacted in the head. We went through the pancreaticoscope up to the stone. Then with the laser, actually you should remain away from the stone. Otherwise, it can cause the burns in the stone. You can break the stone and then pass a stent. So through the stent, therapy is also a rescue therapy in these type of cases. A new method is transgastric peroral pancreaticoscopy, where this case was having a pancreatic head resection for chronic pancreatitis but still having pain. In that case, through the stomach, the pancreatic stent was placed for 6 weeks, small size stent with the help of EUS. You can see the wire is not going beyond the stone. So wire was looping behind. And then after that, with the help of that, pancreatic stent was placed. And then after 6 weeks, it was replaced with a 10 French stent. And then the balloon dilatation was done after 4 weeks of that. After balloon dilatation, we can easily go into the pancreatic duct with the pancreaticoscope. Then the lithotripsy was done, and now you can see the dye is going into the duct. Now the principle is that you have to drain the duct from both sides and keep the lumen there for future therapies if you want to do later on. So 2 stents were passed. One was going into the duodenum and second one was staying in the stomach for future therapies. So 2 guide wire were passed. You can see 2 guide wire, and one 7 French stent was pushed into the duodenum and the second one was in the stomach for future therapies if required. Again, this case is a direct cholangioscope. The direct slim gastroscope was used for cholangioscopy with the help of 5 French balloon. The track was dilated with the 10 millimeter hurricane balloon. This is a Cook balloon. After 10 millimeter dilatation, the slim gastroscope can directly be passed with the help of 5 French balloon. Over the 5 French balloon, you directly go into the pancreatic duct. This 5 French balloon goes with the slim gastroscope. So once you are deep in the pancreatic duct, you can inflate the balloon go inside, and with the help of the traction of the balloon, your scope can go inside. And then you can do all the therapies of with the routine laser and EHL for this stone. And the stone actually came out with a balloon only. You can see the stone in the duct, outside the duct. So as sir has shown that this basket and other snare can be used to remove the migrated stent. Normal migrated pancreatic stone which is in the proximal duct can be removed with the help of routine balloon, pet tooth forceps or a basket by catching it. But when it is migrated very deep, you have to use the pancreaticoscope. You can see the basket which is getting open into the deep into the pancreatic duct. It is catching the stent. This stent was very deep inside. So after catching the stent, even then the stent we could not remove. So then we passed the guide wire inside. We cannulated the guide wire and this. Then with the help of the normal snare, it was removed. Over the wire, the normal snare was passed. And it was removed with the help of the snare. So you can use a normal snare. Otherwise, you can use like Dr. Mahadev has used in this case. Once you pass the guide wire, you can use this Sohendra retriever. 7 French or 8 French according to the size of the stent, and then you can pull out the stent with the Sohendra retriever. Again, there are sometimes after even breaking the stones, it is very difficult to remove the fragmented stone which has gone into the deep into the duct. So you can your spyglass basket easily can catch those stones, and then under direct visualization you can remove this with the help of the basket. You can see the basket grabbing the stone in the pancreatic duct, because the pancreatic duct is tortuous, balloon cannot catch this. Sometimes even with the basket also you cannot catch because of the space is very small. Then you can use the same snare, small snare, size snare to catch the hold of the stone. With the help of the small stone, you have to catch it in the middle of the stone, like foreign body. Then you can remove this stone. And the most difficult is the stone in the duct, which is minor ducts, the branch ducts. So where the snare and basket even don't open. So at that time you have to use the spy bite forceps. So that spy bite forceps you have to maneuver according to the size of the stone and according to the place of the stone. So this spy bite forceps can open, because this looks big but they are very small, 6-7 millimeter stone. So the spy bite has a 1 millimeter diameter after opening, 1 centimeter. So you can catch this stone with the help of spy bite. Then you have to take out the stone from the side branches with manuring carefully without breaking them. Once it is out in the main duct, you can definitely remove them with a normal balloon. So you just have to remove it out of the duct, and then with the help of balloon, normal balloon, you can pull them out. The side effect of pancreaticoscopy, as we all know, post-operative pain and pancreatitis, which is usually manageable. There are reports of perforation with the guide wire, and there are reports of patient dying of severe pancreatitis. So we have to be very careful. It should be done. In conclusion, POP has a crucial role in diagnosis and management of pancreatic diseases. It provides direct macroscopic assessment of the IPMN and tumor, targeted tissue acquisition, and opportunity for guided therapy. It has limited to high volume expert centers due to procedural complexity, technical challenges, and the cost. But innovation like larger field of view, higher image resolution, integrated image enhancement, and larger working channel may augment the capability of the procedures. Thank you very much.
I'm sure the quality of cases both speakers have shown might have amazed all the audiences, and both videos shown by both the speakers were very excellent. So I request Dr. Jeffy and Dr. Somin to please conduct and moderate this session ahead. Please share your experiences, your personal questions, and there may be some questions in the chat box which you can address.
So I'll start off the question to Professor Moon. You showed about the basket through the POC. So I want to ask you, whether there has been any complications with the basket, because through the scope, the channel diameter is very small. Any chances of impaction using the basket or snare?
A kind of basket is very small version of conventional basket. So during my presentation is from MTW endoscopy from German company. They have a very, just like a string, like a basket. So there is no chance to impaction or any kind of adverse event using that kind of basket. So another basket is from Boston Scientific. They originally from urology, the removal of urethral stone. It's also very nice. Very small version, very nice. But the problem is the price still.
Yeah. Let me ask you another one. Is it a single use or you use it? I mean, in India, I think because of the resource constraints, we have been using, this even the cholangioscope at least for 3 to 4 times. So your accessories, if it is a single use, or you will use it the second time if it is?
Accessories are single use, but the problem is the price of the spyglass DS. It's also we cannot get some reimbursement from the patient, even in Korea. So the company strictly asked to single use only policy, but the real clinical practice is some different. Even our institute, we are using 2 or 3 times per one scope.
Yogesh, you are not audible.
My question to both speakers, is there any technique to make the scope stable within the pancreatic duct or within the CBD? Sir, you showed a technique of balloon that we have to give traction to the balloon. Can we perform this in CBD also?
Yes, we can do. With the traction, we can do this. But with the parabolic cholangioscope, new cholangioscope, you don't need. You don't need to, because it directly goes in the and it is very stable. So we are waiting for that.
Two bending.
Two bending. So actually, we have used normal gastroscope, even double channel gastroscope in common bile duct. But for pancreatic duct, it is very difficult. You can use only slim gastroscope. You cannot use the normal.
Pediatric one, sir. Slim.
Yeah, slim. Yeah, 5. Yeah, same one. Actually, we have done few ERCP with the gastroscope also. Same gastroscope with the cap. Normal gastroscope with the cap in difficult position. Whenever we are in difficult position, we are not getting position in the pancreas, CBD or pancreas. We can use normal gastroscope to cannulate, do a small sphincterotomy, and then we can use the normal ERCP scope. We have 6 cases like that doing normal gastroscope ERCP.
So the balloon which you showed, sir, has to go through the spyscope, you know?
Yeah. No, the balloon should go for 2 millimeter channel. That is for the normal gastroscope.
Okay.
5 French balloon. It goes with the normal gastroscope, small slim gastroscope. 2 millimeter channel, 2.1 millimeter.
Great.
So, sir,
there is a question about pancreatitis after cholangioscopy. So the problem is cholangitis and not pancreatitis. Actually, pancreatitis is not so high incidence by the polar cholangioscopy or pancreatoscopy. The problem is cholangitis.
What are the routine precautions you take for preventing cholangitis in your hospital?
Our hospital antibiotics should be mandatory before procedure and after procedure. And like a spyglass DS, we are using a lot of amount of normal saline flushing. You should keep in mind the amount of installation of normal saline should be removed from the bile duct. And a low pressure to preventing spreading some prurient bile inside the bile duct. So gentle pressing the normal saline is also very important. And direct polar cholangioscopy is the same. Usually for direct polar cholangioscopy, we are using saline also. So same, but the advantages of direct POC is we can easily removal of normal saline comparing with spyglass DS because it has a suction channel differently.
Any endomethacin do you use? per rectal endometasis before?
Actually, it's not available in Korea. So
Because
just
now,
the root.
now we have availability of endometasis per rectal.
Great, great.
Sir, in my question to Dr. Rajput, sir, in pancreaticoscopy, sometimes it happens that there may be multiple strictures or there may be very tortuous PD. So, is it technically feasible to go till the distal PD with pancreaticoscope in case of tortuous PD?
Usually, tortuous PD is no problem, but in multiple stricture, we don't do pancreaticoscopy. Because it should be avoided. It should be sent for surgery. With multiple strictures, usually you should not do because there are more complications.
But in single stricture, you showed one video where you have placed
Yeah.
the stents and through
Bumpy
the
stent. Yes, we put one bumpy stent, dilated the stricture, and then we remove the stone.
So how long you wait for the procedure after the stent? Immediately or?
Every bumpy stent should be removed after 4 weeks. So we don't want 2-3 procedures. So while removing bumpy stent, we should do this procedure. So it is always better to do less procedures rather than removing it after 2 weeks and then doing procedure and then. So call them for after 4 weeks so that the tract is also dilated and the removal of bumpy stent also helps. Then you put plastic stents later.
And sir, what is your experience for if we compare ESWL and EHL in pancreatic stones?
ESWL good for multiple stones, and for single stones, dilated duct always this, because single session therapy is always helpful rather than sending patient for multiple sessions. So it is also cost effective and safe, because ESWL itself is not safe. We have seen patients of pancreatitis, we have seen patients of perforation after ESWL, severe pancreatitis, and one patient died after severe pancreatitis, ESWL. So it is not safe.
You showed one case of pancreaticogastric fistula. A stent was put, a post-operative patient after Whipple's. So how long do you place that pancreatic stent?
It should be followed up for 12 months. Every 3 to 4 months, you see the patient.
And finally,
that remains open. Yeah. Usually, you put a stent. It is called a ring drainage. You put a stent which goes one end outside the jejunum and one in the stomach. So this remains open from both sides, and you can keep this stent for very long time. Studies have shown that if you keep them for even years, it doesn't matter because it doesn't get blocked so often than the routine stomach stent. You put the stents in the stomach. So if they are having drainage both sides, most of the time you can keep them and patients are not as symptomatic as with a single side stent.
So one question to Dr. Moon, sir. Spioscopy, sir, as you told, it is a single use. In India, we may use 2 or 3 times. But the same wear and tear we see in cholangioscope also, or it is different?
It's same.
So cholangioscope also, the use is limited to 3 or 4 scopies per scope.
No.
No. For you mean direct cholangioscopy? No. It's
very sturdy.
Direct POC is like a routine ultrasound gastroscope. Unlimited. You can use it multiple times. Like in my experience, at least like 100 times.
So, Saumin, do you have any other question?
Sir, up to what level of hepatic lesion? Suppose second and third generation hepatic duct have some lesion. Can we assess with this cholangioscope spyglass? Can reach up to second and third level of hepatic duct? Second generation, third generation.
It depends on the degree of dilatation of intrahepatic duct. Some patient is dilated intrahepatic duct. It's very easy to insertion of direct POC or spyglass to second or so the sectoral bile duct. But some patient is very narrow, like sclerosing cholangitis, impossible. Depend on the diameter of intrahepatic duct side.
Can we do it in sclerosing cholangitis because there is risk of severe cholangitis after POC? So should we do or should we avoid? In sclerosing cholangitis, should we avoid or we can do it?
Well, we could do that. We could do that. Especially Western countries, they are dominant patient of sclerosing cholangitis. So spyglass can be done. For direct POC is difficult because the diameter of tip of direct POC is 5 millimeter. So maybe sclerosing cholangitis is spyglass D is much better.
So what is the minimum cutoff you for the spyglass DS above which you don't do the procedure, the CBD diameter for spyglass DS?
Spyglass DS is all that can be done. So there is no limitation actually, except very narrow the CBD, but almost all patient can be done with spyglass DS. But the direct POC, our institute minimum diameter is 8 millimeter.
And do you routinely perform introductory ultrasound before POC?
Yes, introductory ultrasound is a routine clinical practice in our institute.
Sir, is it better to put a stent in CBD after each and every cholangioscopy to prevent the cholangitis, even if you just take a biopsy? Is it helpful if you put a stent, plastic stent, to prevent a cholangitis because of spike? So can we make in routine clinical practice that after each and every cholangioscopy for any indication, you just give a per rectal endomethacin followed by your completion of procedure, just put a plastic stent to remain safe?
So his question is that after every cholangioscopy, only if we do it for diagnostic purpose, we take a biopsy. So is it important that we should put a plastic stent to prevent post-procedure cholangitis?
Okay, how about your opinion? Sanjay?
Actually, we always put, because we reuse the scopes. So we always put, sir. In our setup, we always put. It is safe. Because cost of the stent is less than the cost of the antibiotics.
So, Jeffy, I think if there are no further questions, so you can give a conclusion remark, please.
So I think it was an excellent presentation to listen to some of the great gastroenterologists and endoscopists in the field of cholangioscopy and pancreatoscopy. We learned new things and could see more videos and could throw more light on our approach to the management. And it was a very nice and interesting interactive session. And thank you, Professor Moon and Professor Rajput, for the taking your time of your busy schedule and throwing light on this important topics. Thank you very much, sir.
And sir,
Thank you.
Thank you very much.
Thanks to
Recording vocal.
Bye bye.
Special thanks.
Have a nice Sunday. Bye bye. See you soon.
Yes, same to you, sir. Thank you.
Bye, sir. Thank you very much.